Now, Ivan is also a knee, shoulder and elbow surgeon who enjoys his music as well as surfing with a young family as well. And Ivan's going to talk to us today about the posterolateral corner.
Okay, so just carrying on from where John left off, the posterolateral corner is one of the more common times we need to think about extra capsular ligaments and reconstructions. So the incidence of posterolateral corner injuries compared to all ligament injuries in the knee is quite rare, only about 2% of total ligament injuries. And they're usually associated with injuries to other ligamental structures in the knee, and isolated posterolateral corner injuries compared to the total of posterolateral corner injuries are only about 28%. The most common associated injuries are tibial plateau fractures, mainly because of mechanism of injury. You normally fracture your tibial plateau in an axial loading injury close to full extension with either a varus valgus force, which can load up the posterolateral corner. And the incidence rate is actually very high. From soft tissue point of view, the most common associated injuries are with the ACL and PCL, and this reflects the complex interrelationship with knee stability of the posterolateral corner and the cruciate ligaments, which we'll go into shortly. It's very important to identify posterolateral corner injuries because all high-grade posterolateral corner injuries need surgery. There's no role for non-operative management of these at all. And more importantly, it's very important to get these early. Ideally, you want to operate on a high-grade posterolateral corner injury within 3 weeks. After 3 weeks, the tendons become scarred, retracted, hard to identify, to the extent that a chronic posterolateral corner injury is considered one that's 6 weeks post-injury. So you haven't got much time to identify these patients, get them referred, assessed, and operate on before they'll need a reconstruction rather than repair. If you don't identify it and the associated cruciate ligament is repaired, they have a very high failure rate because they don't have the secondary supporting structures of the posterolateral corner. Untreated posterolateral corner injuries have a very poor function, which we'll come into later on, and very high risk of osteoarthritis. So it's important to identify these and treat these early. Basically, the function of the posterolateral corner, you can divide the two parts. It's quite complex, and the important thing is to try and simplify it. The lateral collateral ligament, or the fibular collateral ligament, is the primary restraint of the varus force in the knee. And the rest of the posterolateral corner is mainly concerned with controlling external rotation, and the lateral collateral ligament of the rest of the posterolateral corner act together to limit hyperextension. But there is also a secondary restraint for internal rotation. The ALL, which Duron was talking about, is a component of the posterolateral corner. And the popliteus tendon also has a role in limiting external rotation, presumably through its attachment to the fibula and the popliteal fibular ligament, which we'll come on to soon. So it can be further divided into the primary stabilisers of the posterolateral corner. This is the fibular collateral ligament or the lateral collateral ligament, the popliteus tendon, and the popliteofibular ligament, which I'll show the anatomy soon, and the secondary stabilisers, which include a plethora of anatomical structures. And this whole complex used to be known as the arcuate complex. As we're getting slightly more sophisticated in understanding and reconstructing these injuries, we start appreciating the individual components of the structure. So it includes the meniscal tibial, meniscal femoral ligaments, the peroneal ligaments, the lateral gastrocnemius, the fibular ligament, the ITB and the ALL. So this is the anatomy of the major structures. So this is the fibular collateral ligament running from the anterior fibular head up to a portion just proximal and posterior to the lateral epicondyle. The popliteus running from the posteromedial aspect to the proximal tibia, obliquely attached to the popliteal sulcus, anterior and inferior to the lateral epicondyle. And this is the popliteal fibular ligament. It comes off from the muscular tendinous junction of the popliteus and runs forward and attaches to the posterior aspect of the fibular head. So these are the major stabilising structures of the posterolateral corner, and these are basically what we aim to reconstruct in chronic injuries. Now, mechanism of injury. If you're going to injure your posterolateral corner, this is a pretty good way to do it. This is actually a photo of Dr Goldberg minutes before he decided that maybe rugby union was the game for him. Anyway, so basically a posterolateral force on an extended knee is a very good way to rupture your posterolateral corner. It can also be torn in combinations of hyperflexion, external rotation, large varus forces, and it should be considered in anyone who's had a knee, it will be ruptured in anyone who's had a knee dislocation with intact medial structures, okay? The thing is about it, this hurts. You know, this is a bloody painful injury. So it's not this, I was running and felt a pop and could keep going for a while. These are significant injuries. So the patient, you know, the diagnosis of this, these people present different, you know, if they've got a grade 3 posterolateral corner combined with an ACL, PCL, they're not sort of coming like this into your rooms, their knees wobbling all over the place, they often got a crutch. They look a bit like Long John Silver, you know, they're just limping all over the place. They've got bruising, often have bruising and gross tenderness and swelling over the posterolateral knee. So you've got to suspect it when someone's had a significant injury like this and present with those that sort of sign. If it's chronic, you might actually be able to demonstrate a varus thrust. So if they're walking into, they're doing this sort of thing. So it causes marked disruption of knee biomechanics. Clinical tests. To test the lateral collateral ligament, the varus stress test is the easiest to do. So test varus stress looking for valgus joint opening at both 0 and 30 degrees. At 0 degrees, you've got both. If you've got increased laxity, you've got both the PCL and lateral collateral ligament injury. At 30 degrees, it's lateral collateral ligament only. And it's important to understand that you can to your rested posterolateral corner and have an intact lateral collateral ligament and vice versa. So you need to be able to differentiate between the two entities. My favourite test for the posterolateral corner, looking at the external instability and external rotation, is a dial test. It's very easy to perform. It's not particularly traumatic in the patient. It's very reproducible. So what you do is you have the patient prone on the bed, their knees are together and their femur is controlled. You externally rotate the feet and you compare to the other side. You externally rotate at 30 degrees. If there's a difference of 10 degrees and greater on the injured side, that is an injury to the posterolateral corner. If that difference persists at 90 degrees, you have a combined PCL and posterolateral corner injury. It's as easy as that. There are other tests, but those two are I think the most predictable. The other thing is the external rotation recurvatum test is again very easy. You pick up the patient by the toes and their leg falls in external rotation recurvatum. Moving on to investigations. You may see a telltale fracture on an X-ray, but often the plain X-rays are normal. But what gives you a clue? This is a fracture of the fibular head. This is what's called an arcuate fracture. So if you see that, you've got to suspect very strongly they've got a posterolateral corner injury. Or in fact, by definition, because they've avulsed the lateral collateral ligament, they have got a posterolateral corner injury. The other thing, as Jeron was saying, the Sagon fracture, the capsular avulsion of from the tear of the ALL. That's pathognomonic with ACL injuries, but it's also pathognomonic of posterolateral corner injuries because ALL is part of the posterolateral corner. So it doesn't mean that necessarily it's unstable, needs reconstruction, but needs to be investigated. The rest of the posterolateral corner needs to be examined. Stress view is obviously very good for assessing, valgus opening with varus force. And if the patient is a chronic injury, so if it's greater than 6 weeks and they've got a varus knee, you'll need to know about it because they'll need a high tibial osteotomy before you can reconstruct the posterolateral corner. Acutely, you can reconstruct the you can repair the posterolateral corner in a varus knee, but you can't do a reconstruction one. So that increases the morbidity, the length of time, the number of surgeries. So you want to get to them early if at all possible. Of course, the investigation of choice is the MRI scan. You can see here a avulsion of the lateral collateral ligament and gross disruption of the posterolateral structures. Here's the fibula. This is a lateral collateral ligament, a biceps femoris avulsion. That's the lateral collateral ligament avulsion with the stripping up of the posterolateral capsule. So you can grade these, just the standard grading system with varus instability. 0 to 5 is 1. But adding in the rotational component, 0 to 5 degrees is a grade 1 of external rotation, grade 2, 6 to 10 millimetres of valgus opening, or 6 to 10 millimetres of excessive external rotation. Grade 3 is greater than 10 millimetres, no end point, and external rotation greater than 10 degrees. Going on to treatment, it's been pretty well elucidated that all grade 1 posterolateral corner injuries do well with non-operative management, and most grade 2 do well with do well with non-operative management. Although there is a small component of grade 2 injuries which tend to stress out over time, and in more athletic patients may need late reconstruction. They, however, don't tend to get the arthrosis you see in grade 3 injuries. Grade 3 require surgery. We've talked about the need for early repair. So moving on to reconstructions, there's basically 2 types. There's non-anatomic reconstructions, and as John talked about the ALL, there's an absolute plethora of these. Some make sense, some don't make so much sense. They do sort of okay. But there is a tendency for them to stretch out over time and that not restoring the normal knee biomechanics to the same degree as an anatomical reconstruction. This is an early one. It's called a Clancy biceps tenodesis. And the way you perform it is you put a screw with a washer in the lateral epicondyle, you mobilise the biceps femoris tendon, and you drag it up, hook it over that screw and tighten the washer, okay? So that reconstitutes the lateral collateral ligament. As a nature of dragging that tendon up, it tends to tighten the posterior capsule, and it's normally combined with the posterior capsular plication. What it doesn't do, though, is it doesn't do much for your hamstring function, particularly your lateral hamstrings. And if the patient's had an ACL using the obviously, gracilis and tendinosis are not a particularly good option. So moving on to anatomic reconstructions, these are getting more complicated as we understand the structure of the posterolateral corner. This is called a Laplace reconstruction, and basically using allograft, you can and drilling various holes in the fibular head and through the tibia, can reconstruct the lateral collateral ligament. There's a reconstruction of the popliteus, and that's an attempt to reconstruct the popliteal fibular ligament. And these are sort of returning the injured knee to a more normal biomechanical state, and are pretty effective to get reasonable knee function. So outcomes. Non-operative treatment of grade 3 injuries shown to give demonstrably poor function. The patients have gross instability, the difficult ascending stairs, squatting, uneven ground, and they get early osteoarthritis. 50% of patients with untreated grade 3 injuries have bicompartment osteoarthritis in 8 years. So it's a devastating injury to the knee. Interestingly, rabbits, if you transect their posterolateral corner, will develop chondromalacia within about 12 weeks, which is bad news for rabbits. How it relates to us is unclear. Okay, so all grade 1s do well, most grade 2 do well, though some get significant problems and need repairs. Now when you're looking at studies for these, they tend, because it's not that common, they tend to get a lot of injuries thrown into the same group. So there's, patients, normally a study looking at posterolateral corner and treatment will be half the patients will say two-thirds will have a PCL tear, 20% will have an ACL tear. There's a whole hodgepodge of injuries. So it's hard to make any real definitive conclusions to a lot of these studies. But it does appear that acute repairs do better than reconstructions in general, although there's a caveat to that which we'll come on to later. At 4 to 6 weeks, there's a grey area where is it better to do a repair or is it better to do a reconstruction? That's sort of somewhat unclear at present. After 6 weeks, there's no doubt the reconstructions do better than repairs, and anatomical reconstructions appear to do better than non-anatomical reconstructions. We've talked about varus knees requiring HTOs. Now, there are some studies, there's one by Sanford and one by Levy, showing a high rate of acute repair failure compared to reconstructions, even in early surgical treatment. And their failure rates in the acute repair group was about 40% compared to 9%, so it was quite significant. What may be complicating that study, however, is that both groups had an early aggressive mobilisation program. So what they might be studying is the effect of early aggressive mobilisation on repairs compared to the effect of early aggressive mobilisations on reconstructions. With new reconstruction techniques and compression screws, we get solid, rigid fixation quite quickly. So you can, it's just like nowadays with the ACL, we can get the knee going very quickly. If you're actually putting intertendinous sutures and repairing the soft tissue component directly, that repair may not be strong enough to tolerate early aggressive mobilisation. So that may be what that study demonstrates. So a devastating complication, unfortunately not an uncommon complication of posterolateral corner injury, is a common peroneal nerve injury, and that occurs in about 1/3 of patients. And the reason this occurs is that the common peroneal nerve is effectively tethered to the neck of the fibula. If it's put under a large valgus stress, it'll be isolated as the other components of the components of the posterolateral corner fail, and it's put under a lot of stretch. Sometimes it can tear, most often it's left in continuity. The other problem with it is at that level it has a very vulnerable blood supply, so often the trauma associated with posterolateral corner disruption can affect its blood supply, and you can get a segment of the nerve becoming ischemic. Spontaneous recovery is variable and it's not that great. Best studies, maybe half get better spontaneously, and some significantly less than that. A good prognostic indicator for recovery is young age, less than 30. The treatment acutely is neurolysis. I mean, you want to be repairing these people acutely anyway, so you're in there, so you dissect out the peroneal nerve. If it's torn, you want to basically repair it or reconstruct it. But neurolysis does appear to have a beneficial effect. If it can be directly repaired without any tension, that is the treatment of choice, and it has a reasonably high success rate. Most, however, need nerve grafting. And this is a compound nerve, so both has motor and sensory fibres, so the recovery is quite variable. And what it's starting to do now. So if the patient has got a common peroneal nerve injury, they need to be placed in an AFO to stop them getting a quinovarus deformity. But there is a trend now to go to early tendon transferring the posterior tibialis posterior tendon to the medial into the cuneiforms to regain active dorsiflexion of the foot. And even in the context of a recovery of the nerve post-repair or post-grafting, this has been shown to have a better outcome than treating the patient in an AFO. And you can always reverse the transfer down the track. Okay, thank you.